So today we're going to actually tag team the presentation. I'm going to give you a brief introduction of UCL just to give you some context of our size and scope, and also talk through what the last 18 months have been during the pandemic. Just like all of you, we've struggled with capacity and managing it, and really have relied on the lean TOS tools, and we'll talk through that. Mohan is going to go through the methods and the way that lean TOS as an intelligence vendor thinks about managing capacity and helping all of us out within health systems. And then I'm going to loop back at the end and talk about some of the successes that we've seen with our partnership with lean TOS. So this is UC Health, University of Colorado Health. We are located mostly in the state of Colorado, but we do have some presence in Wyoming and Nebraska. 5.6 billion, 12 hospitals, about 6,000 plus providers, 2,000 beds, and 4.1 million plus ambulatory visits. So we do have an academic medical center, the University of Colorado Hospital, but all of our other hospitals are community-based, from 600 beds down to essentially 20 beds. So large and small and academic as well. So from an IT perspective, we have a single instance of Epic across that entire footprint, inpatient and ambulatory. We first went live with Epic in 2011 and have brought on all those hospitals over the last several years. And so we have a large patient portal presence, and we also have developed our own mobile app for Android and iOS that then integrates with Epic and all other tools. So we have about 7.3 million patients in our Epic instance. So hopefully with that, you have some semblance of the size and scope of UC Health. From a COVID perspective, like all of you, a lot of our attention in the past 18 months is how to run a health system, inpatient and ambulatory, and also take care of a pandemic. So like many of you, our health system has become a little bit of a public health agency as well, trying to provide testing, COVID care, vaccines, and so on. So this pandemic has tested our fortitude and will like nothing I've ever seen, but also has tested our capacity challenge and challenges across ambulatory, across OR, across inpatients, and so on. So hopefully today we're going to paint a picture for you of what we've done pre-pandemic, during the pandemic, and hopefully as we're starting to come out of the pandemic. But you can see there from this chart that we had 260 some COVID positive and rule out patients in our 12 hospitals back when the pandemic first started in late winter, early spring of 2020. And then we had a huge surge in late fall, early winter. And now we're kind of in this next surge, which essentially mirrors what we first saw the pandemic. So we're about 260 this morning across our 12 hospitals. So again, the difference between what we're seeing now and what we saw, a good 18 months ago now, was that we now know how to treat this disease. So it's very different. The mortality rate's much lower than what it used to be, but we are extremely full. So not only do we have this number of COVID patients, but unlike the first surge where we started to delay, defer elective surgeries, we are not doing that now. We don't have ambulatory clinics closed. So therefore, we are now very busy health system taking care of COVID patients and non-COVID patients. Some of the other things, just like many of you, again, just to give you some context for how we responded to the pandemic, I'm sure it mirrors your experience too. We actually had a lot of advanced capabilities set up at UC Health prior to the pandemic. And what the pandemic did was allow us to essentially scale that. So for example, we had integrated virtual visit capability with our Epic platform in February of 2022. We saw about 1,000 virtual visits. That includes primary care, specialty care, and urgent care. So we saw about 1,000 visits in February 2022. We scaled that platform to 77,000 just 2 months later in April 2020. And we've kind of normalized in that 20,000 to 30,000 range per month. So in August, we were at 25,000. The virtual visits on top of the bricks and mortars actually allowed us to see more patients at UC Health. And again, without the integrated Epic instance and tools like lean TOS, IQ, I'm not sure we've been able to do this. So some really good stuff that our IT teams and our IT platform allowed us to do to respond to the pandemic. We also essentially had a virtual health center stood up that did things like fall sitters, telemetry monitoring, virtual ICU. We also then turned that virtual health center into essentially an RPM center. We can send patients home on Masimo wearables and monitor them after discharge to make sure that they don't deteriorate and or need to get readmitted. So a lot of things during the pandemic were put in place because of our capability pre-pandemic that allowed us to scale and help with the capacity challenges. A couple other things, UC Health is, I think, we're awfully proud of our response across the Colorado and Wyoming, Nebraska community. The IT teams did some things around symptom checking. We also had our own vaccination card integrated with essentially the VCI initiative. So all of our patients can actually see the vaccination card and have the QR code that allows them to go to other states, venues, travel, and so on. And again, like I mentioned earlier, we've almost became extension of the Colorado Public Health Organization, where we were able to do some advanced and high volume testing and also vaccine administration. And we're still continuing to do that. And we're doing the booster doses for Pfizer and Moderna at this point. One of the most exciting things that we did, though, and I think this is a testament to Mohan, the LeanTaaS team, and our partnership with them. So we have a long history pre-pandemic of really leveraging the EHR, leveraging advanced analytics, partnering with folks like LeanTaaS to develop predictive and prescriptive intelligence tools that get layered on top of the EHR to really turn all that rich data that we have in the transactional EHR to insights, intelligence, and not only telling you what happened in the past, but helping you predict what's going to happen in the future, and then turn those predictions into the levers that should be pulled to try to actually control your destiny and change the impact of the future steps that you take. So we've really been able to leverage the partnership with LeanTaaS that started back in 2015, 2016, and really create a foundation of predictive and prescriptive intelligence and take that to the next level during the pandemic to help our operational team. So Mohan and I will talk a little bit about how the IQ products really help transform the way that organizations, including UC Health, has been able to take all this data and turn it to intelligence. So, without that foundation that happened pre-pandemic, I'm not sure UC Health would have been able to respond as effectively as we had during the pandemic. And now that we have this emerging and even more adopted platform, success is going to beget success as we move forward. Mohan?
Thank you, Steve. Let me switch gears and start talking about optimizing capacity and what it takes to actually execute it. I'll spend the next 10 or 15 minutes doing that and then turn it back to Steve to talk about the practical applications at UC Health. Quick one-line description of who are we. What we do is crazy math, sophisticated data science, web-based software to unlock capacity. That's what LeanTaaS does through our products. We've got 3 products in the commercial marketplace: IQ for operating rooms, IQ for inpatient beds, IQ for infusion centers. Collectively, we work with over 400 hospitals, more than half of the top 20. It comprises of 110 different health systems spanning 41 states in the US. So a fairly solid footprint, recognized by lots of innovative awards and so on, which I won't drag you through. So why capacity optimization? What's shown here are 3 service delivery things with very high standards and expectations of how service is done: package delivery, airport operations, or security in the airport. Now, what's common across all of these? First, that demand is very, very hard to predict, and the supply is hard to move. In that world, they managed to make it work. How is that? They've got very sophisticated demand supply matching algorithms under the hood. It's yield management, it's route planning, it's those sorts of things. One could expect the same thing is true in health systems too. An operating room is an expensive asset. Beds are an expensive asset, similarly with oncology suites and so on. And here too, it has the same characteristic. It's difficult to predict with a high level of precision what the demand is going to be. And the supply is complicated. You can't create operating rooms at short notice. The one big difference is health systems have done magic on advances in clinical excellence. However, operational excellence is still paper and pencil, calendar, faxes, online calendaring, rather than any sophisticated equivalent of the yield management or the route planning that I was describing earlier. As a result, when you look across industries, healthcare's use of its assets is an order of magnitude worse than many other industries. So that's the core of the issue. So when you get into what's it going to take, there are two key concepts that it takes to optimize capacity and optimize utilization. The first is this concept of matching. Minute by minute, hour for hour, the demand signal and the supply signal need to be matched as closely as possible through active intervention. So that's kind of one concept. And the second concept is linking. Healthcare is a series of individual services that are strung together to provide an entire patient encounter. The way in which you navigate those connected services is a concept of linking, which also needs to be done. When you're trying to match supply, what's on the supply side? It's the staff. You need the right providers, the right nurses, the right technicians with the right skills at the right time in the right place. You need the right equipment, whether it's pumps or robots or imaging machines. And you need the right kind of facility, a procedure room, an OR room, an exam room, an infusion chair, et cetera. So on the supply side, you've got an interconnected, constrained, hard to predict capacity situation. On the demand side, how many patients, what kind of patient, when will they show up? Will they be late? How long is their treatment? All of that makes the demand vector. Again, hard to predict. And into the future, it's particularly difficult. So now you've got to try and make these two match. When we point these out to health systems and say, trying to do this off of a calendar is simply not going to work, health systems rightfully say, yes, but this is a very hard problem. It's interconnected, it's constrained, it's hard to predict, et cetera. And we agree with all of that. What we offer up as a aspiration is say, think about what Uber has to do. They build demand forecasting models by time of day of week, by zip code, weather, seasonality, traffic, construction, et cetera. They build an accurate demand vector. On the supply side, they mine the driving habits of all the drivers. Who drives when, where, which zip codes, for how long, which days of the week. And they try and make it match actively. If it doesn't match, they change the driver incentives to bring more of them out to drive. Health systems do none of these things. And this is why it creates this peak effect in many, many areas of the capacity. The second concept is linking. When you think about linking, a patient bounces through many independent services. They get their lab done, they get their clinic done, then they go get a procedure. If they bounce through the ED, they might end up in the OR, they recover in the PACU, and then they end up in an inpatient bed. All of these are distinct and different services, and they're strung together. The top one, which is scheduled, the itinerary is just made up by examination. Somebody who schedules will say, well, you're seeing the doctor at 9, how about you come at 8 for the labs, and we'll squeeze you in at 10 for the procedure. Nobody ran any optimization math. There's an entire class of mathematics called topology optimization or directed acyclic graph theory that allows you to traverse a network of nodes in the most efficient way possible. That doesn't even exist. By contrast, airlines will spend 3 months and run simulation models millions and millions of times before they come up with a connected flight schedule, because they too are stringing independent services. The Seattle to Chicago flight is one service, Chicago to New York is a different service. They've got to string the two together and have the right connect time in Chicago, allowing for de-icing and the size of the gates and the hubs and all of that. That's why it's a hard problem. Okay? Now, let me give you an example where both matching and linking are done brilliantly. We've all sat at the airport while a plane pulls in, and then 45 minutes later, we get on the plane and it pulls out. Think about all the services that happened. Above the wing, they put in a new crew, they restocked the food, they cleaned the cabin, they kicked out 200 passengers, they put in 200 new passengers. Simultaneously, below the wing, they checked the flaps, threw out suitcases, put in new suitcases, refueled it, and checked the engines. All of these services, 10 or 15 of them, happened nearly simultaneously. They all happened within 45 minutes. They happened thousands of times a day, and they happened nearly perfectly. 99.99 is not good enough. It's got to be, very, very close. Now, what does this have to do with matching and linking? Well, you have to match. Why? Let's take baggage handling as an example. Baggage carts move at 5 or 6 miles an hour. They break the airport up into 20 zones. In each zone, they know how many pushbacks, they call it pushes, will take place every 15 minutes. So they know in zone 1, between 8 and 8:15, there will be 7 pushes. 8:15 and 8:30, there'll be 5 pushes. Based on the pushes in that zone, they put the right number of tows, tugs, ramps, people to execute the baggage function. Similarly with fuel, similarly with catering, similarly with cabin cleaning. So they've matched it to a very precise level with 15-minute windows in mind, with solid predictions. What does it have to do with linking? Well, there's an order of operations. You cannot clean the cabin unless you've kicked out the passengers, but you must clean the cabin before the new passengers come in. So they figured out how to sequence it. Fuel and baggage can't be under the wing at the same time. Why is this valuable? In the 80s, Atlanta Airport could do 500 flights a day. Today, Atlanta Airport does 5,000 flights a day. So there's a 10x velocity with the same quality in a world where the airspace hasn't changed and the number of runways has barely changed. It used to be 4 runways in the 80s, it's 5 runways now. So a 25% modest increase in capacity has allowed a 10x velocity. Imagine if we could do this in health systems. Maintain the quality of clinical care, maintain the touch with patients, but yet improve the capacity and the flow through the magic of solving, matching, and linking at scale, not with simple little Excel spreadsheets, but solving it in a sophisticated manner. Now, how does this manifest in other cases? Take beds, for instance. What happens with beds is in the morning, the admission rates start to climb because people come out of their procedures and are looking for a bed. However, discharges only start to happen in the afternoon. So you've got this horrible inversion layer late in the morning, early afternoon, where the demand exceeds the supply being unlocked. And every hospital sees this every day. The EDs get backed up, patients get boarded at the PACU, patients get wait in hallways for their bed, etc. And like Groundhog Day, this repeats every day. So this is the core issue. Similarly, if you think about surgery, these are the minutes or the number of cases done by 4 different surgeons. And the number of cases a surgeon will do on a given day depends on who all came and saw the surgeon the weeks leading up to it, what percent of them needed surgery, what percent of them could do it on the day the surgeon happened to have block time, and how the lengths fit in that block. So in the face of this highly volatile, unpredictable demand side, how are OR block times allocated? In fixed chunks. Dr. X gets Mondays and Wednesdays. The orthopedic service line gets 4 rooms, Tuesday, Wednesday, Thursday. So a fixed allocation of a capacity while you've got a crazy volatile demand signal is of course not going to work. This is why if you walk through any health system, you'll find ORs empty in the day and the same ORs will be running at 9 o'clock at night with overtimes on staff. 30% of the people operating on a given day are not even using their own block time. They're using someone else's block time. The number of urgent and emergent cases that are pushed onto the grid are not really urgent and emergent. That was the only way to get them on the grid. These are all Band-Aid solutions because the underlying supply-demand math wasn't solved correctly. Now, the EHRs are fantastic at putting all patient information in one place, being the single source of truth, capturing every encounter, capturing the billing, etc. They are not built for optimization. So they're simply not able to do that. They push a grid-based scheduling method where you can see grids in every health system on snapboards, on TV screens, on Excel spreadsheets, etc. Grid-based scheduling works when you're scheduling tennis courts or when you're scheduling conference rooms because the start and the end time are not random. They're very well known. They're very fixed in duration. Tennis courts for an hour, conference rooms for the length of the meeting, etc. First come, first served is mathematically flawed, yet that's what EHRs do. EHRs also have no capacity to do probability theory, simulation, etc. Anytime there's complicated scheduling, these methods apply. You cannot book 3 appointments into 2 slots. You cannot book a 5-hour appointment into a 2-hour slot. As a fallback, what every EHR has done is created dashboards and reports and created a whole infrastructure around it, certified report writers and so on. Dashboards and reports are nice. They're not enough. A better scoreboard will not win the football game. a sophisticated understanding with AI and ML and simulation and optimization and predictive analytics to solve this problem. Let me turn it back to Steve to talk about how these have been deployed.
Thanks, Mohan. Yeah, so as I mentioned earlier, our journey with LeanTaaS has actually been multiple years. And as I mentioned earlier, we actually implemented Epic back in 2011 and scaled to our major hospitals over the next couple of years from there. And here's what I was seeing. So try to rewind back to 2013, 2014. What I saw was a enterprise EHR, world-class, best-in-class, doing all the right things. At that point, we had developed hundreds of thousands of reports, some canned off the shelf, some developed by our team, and a really amazing data telling everybody what happened yesterday, last week, last month, last year. And what I also saw was a bunch of reports that weren't getting used at all or getting used once and then shelved because it didn't quite answer the question. But those reports that were getting used, what I kept seeing was our operational partners continuing to struggle with, now what? What do I do with this data? How do I actually impact operations for our patients? So even though we were producing all this great data and had all this data at their fingertips like never before, they were still struggling with, now what do I do with that? So we partnered with LeanTaaS back in 2015 and essentially piloted what was then called IQ for Infusion. And we went after our outpatient infusion centers, chairs, beds, and we had staffing that was rich in overtime, and we had huge delays between 10 a.m. and 2 p.m. And we just couldn't crack that nut using Epic, using our reports and so on. And we implemented IQ for Infusion. So, and I'll show you the success here in a moment. We then said, okay, what other big, expensive healthcare real estate's out there that is another tough nut to crack? That lots of data, lots of capability, but we're just not moving the needle. So we turned our attention with LeanTaaS's help to the OR, hence the birth of IQ for operating rooms. And then most recently we said, okay, what's next? And really the holy grail is how to manage that inpatient capacity, which has all kinds of inputs around direct admits, ER, operating room admits, ambulatory, and so on. And if we could crack that capacity nut, well, we're really onto something. So that's kind of our journey with LeanTaaS. So going back to infusion, we implemented infusion at our main academic medical center, outpatient infusion center, and have subsequently scaled to all of our infusion centers across UC Health. And the nutshell story here is that same footprint, same staffing, we've increased our volumes of infusion patients and visits dramatically. So revenue, patient satisfaction, leveled off some of those really, those boluses of times during the day, and decreased wait times, decreased drug wait times while increasing that. So, the classic multiple faceted win. So, and that's really been sustained even through COVID when kind of everything went haywire. We still have seen really good patient and operational outcomes. For the ORs, we've started with our main academic medical center inpatient OR suite, and that has subsequently expanded to all of our ORs. And you can see from this slide that it works. It works in large, complex inpatient operating rooms, large, complex outpatient operating rooms, down to some of the smallest ASCs. It works because it really allows you to take all this great data and create that intelligence out of it. So you can see some of our metrics here. So I think we still have a ton of opportunity within the OR that the LeanTaaS IQ tools have delivered for us. But we've really done two things here. One is we've increased the intelligence for our peri-op operators to really have that conversation with our surgeon partners and their schedulers and so on around how to optimize block time, how to optimize room utilization, and move that room utilization percentages up quite dramatically. But like Uber has created, we've created this marketplace of hospital operators and surgeons who can now actually collaborate and actually use time in a free marketplace, in essence, a lot more effectively. And I think this is the part of the change management that's harder for people to understand when you've come from traditional block scheduling and these other kinds of things. But I think this is still ripe for lots of opportunity, but you can see some of our outcomes. Now, the reality is somebody's going to ask us, what's the real financial bottom line here? For the infusion center, we've seen a 10x return of our investment. So if you think about the intelligence that we pay for from LeanTaaS and then the increased visits, volumes, and so on, we've seen a 10x. For the ORs, we've seen anywhere, depending upon the geography, anywhere from a 5x up to a 10x return on ORs. And for those of you that understand the perioperative P&L, those are big dollars. So not only are we looking at operational efficiencies, but the implementation of this intelligence has really delivered some bottom line financial results like we haven't seen from other implementations. And just remember too, that this is not you implement the intelligence and then you just set it and forget it. We're on double-digit iterations of some of this machine learning algorithms with LeanTaaS. So it only gets better over time, and they make improvements to their product suite to the point now where we are probably on version 15, 20, you tell me, Mohan, of our infusion suite and many versions on the OR. So it just keeps getting better and richer and providing more valuable predictive and prescriptive intelligence. So as we start to turn to IQ for beds, again, this is the holy grail. This is probably the toughest of the nut to crack because of all the different matching and linking that's needed. But just to give you some context, we implemented IQ for beds at our main hospital right before the pandemic struck. And right around the same time, we had moved from the teletracking patient placement platform to the Epic platform. So a lot of change going on at once. I'm not quite sure we would have made it as successfully through the COVID pandemic, at least the early days when we were trying to match up ventilators to patients, to beds, to staff, and so on, without the IQ tool. So we really have learned a lot, scaled it to all of our hospitals, and you can see here some of our metrics. Now, a lot of these metrics are things like a reduced transfer time from med-surg to ICU or med-surg to step down or ICU to step down, time to placement. We measure opportunity days. So days that we are keeping patients in the hospital more or less than what some of the CMS length of stay or the average length of stay should be. So opportunity days. So you can measure delays, opportunity days, and you can see reductions. So you can see there that we've actually seen positive trends in all of those measures with the implementation of IQ for beds. I think the third metric, obviously a little bit more subjective, but it's the increase of confidence in decision making. And this is one obviously that's almost impossible to measure objectively, but I can tell you what the tools have done. So many of you, like UC Health, were operating a $5.6 billion revenue system and a 2,000 bed hospital capacity system using Epic. But in many ways, what we're doing is we're pulling data out of Epic and using a tool called Microsoft Excel to actually manage our capacity. Okay. So even though we spent millions of dollars on an EHR, on patient flow capability and so on, we're still using tools using Excel to try to predict out what discharges were going to happen, what admissions were going to happen, and so on. And with those tools that required a ton of manual intervention, manual brain power, we were still extremely kind of inaccurate with our prediction. So we're doing all this effort, and yet no one really believed the data. So now that we've gotten rid of all that manual work, we now have all these automated tools with Epic and IQ. The clinical decision makers, the capacity leaders, trust the tools. They trust the tools now when they actually can look at the data and say, you know what, we look extremely full. The ED looks extremely full, but we believe in the data. We are not going to actually do any diversion interventions, or we're not going to board patients. We can do the interventions. We believe the data, we trust the data, and let's let those natural interventions happen. And so there's something about that organic trust in the system and the data and the tools and the dashboard that is impossible to objectively measure, but frankly, priceless. And that's where we've actually gotten to as a system, as a capacity team using the IQ tools.